once again. So after excellent talk by Dr. Kausik regarding mechanical thrombectomy, he showed very nice cases and where he showed very good result with one pass or two passes. But in real world, things are not so fine as it looks like. And sometimes we have tender lesions and sometimes we have to perform rescue stenting. So around, I would say 60-70% cases go very well, but in 30-40% cases, we always struggle to take out the clot. So my topic is tandem occlusion and rescue stenting. So what do you mean by tandem occlusion? Tandem occlusion is occlusion at two sites in the same territory or same vascular tree. So if there is occlusion in the internal carotid artery, either it is a stenosis or it is occlusion, and there is occlusion in the middle cerebral artery, we label as a tandem occlusion. Or if there is a vertebral artery and basilar artery or PC is involved, then we take as a tandem occlusion. So 30% of large vascular occlusion present with the tandem occlusion. Acute tandem lesions, in 60-70% cases, it is an atherosclerotic plaque. In 20-30% cases, it is a dissection, and remainder it may be carotid web or cardiac emboli, which can produce the tandem occlusion. Tandem occlusion is not contraindication for endovascular therapy, and regardless of whatever etiology you have, either it is atherosclerosis, dissection, or carotid web, still you can have a good recalculation. But identifying carotid pathology is important for planning and execution of the endovascular therapy. So first you must identify what carotid pathology we have. So this is the good slide which says that we can have different carotid pathology and that can be identified on the CT angio. So one is called flame sign. So flame sign is when there is a occlusion is like flame. So the occlusion is distal, but it is contrast is staying here. That is called flame sign, and flame sign is basically indicate the pseudo occlusion. So pseudo occlusion means that it looks that the occlusion is here, but really the occlusion is distal. So if you see on the CT angio flame sign, it is suggestive of pseudo occlusion rather than true occlusion or true tandem lesion. Then there may be beak sign. Beak sign is a small beak-like thing here. On CT angio, you can see the small beak. So small beak may be because of pseudo occlusion, or this may be because of this either atherosclerotic disease or maybe because of dissection. So atherosclerotic disease may have UG calcification, which may identify to say it is atherosclerotic disease rather than dissection. And secondly, you can compare the Hounsfield unit on the both sides. If the Hounsfield unit is less than 45, then possibly it is not because of thrombus, it is because of the atherosclerotic occlusion, because of the proximal occlusion. Sometimes you may have blunt occlusion, so like this. So blunt occlusion may be because of the atherosclerotic disease or maybe because of thrombotic occlusion, but atherosclerotic disease you can identify by the irregular looking plaque or you can identify by the calcification here. So these are some examples. So this is called pseudo occlusion. Here you can see the frame shape occlusion here on the CT angio, but when you perform the DSA, the occlusion was more distally rather than proximally. So this is called pseudo occlusion, and here the aspiration catheter works very well most of the time. Then we can have the atherosclerotic disease, and you can have the complete occlusion like this. You can see here the calcification on the CT angio, which is indicative possibility is atherosclerotic disease. In the DSA, you can find blunt occlusion here, so most likely is atherosclerotic disease. Then you may have the thrombotic occlusion. The thrombotic occlusion may have this tapering and like this, and the contrast is staying like this, and you can have a stent retriever to take out these clots. Or sometimes you have dissection, which is classically seen on DSA as a flame shape. So these are the various pathologies. Either it is a pseudo occlusion or atherosclerotic disease or thrombotic occlusion or dissection, which may mimic as a tandem occlusion in this case, rather than one guidelines here. So if there's a tandem occlusion, either you can do acute carotid intervention or either you can defer the intervention. So when you do intervention, either you can do angioplasty alone or thromboaspiration alone, or you can perform the rescue carotid stenting. In rescue carotid stenting, which approach? Either it is a proximal to distal or distal to proximal. distal embolic protection is used or not, proximal flow arrest is required or not, or what should be the anteplateral region. So we will discuss these one by one. Sometimes you can defer this carotid revascularization in case where there is a no ICA intervention, particularly when there is a large impact volume, if there is a poor prognosis, if it is a pseudo occlusion, or if there is no residual stenosis post endovascular treatment, then you can do the deferred carotid stenting later on. So, what is the potential advantage of acute stent placement? There is a lower risk of stroke recurrence, and there is a improvement of the cerebral perfusion. But what is the advantage of not placing a stent? There is a low risk of the intracranial hemorrhage, because ultimately you have to subject this patient to the double anteplated, and there is more chance of intracranial hemorrhage. There is a low risk of iatrogenic artery to artery embolism, because if you are placing stent here, again there is a risk of the embolization here. There is a no risk of in-stent thrombosis. It avoids delay in the intracranial, it avoids delay in the intracranial reconnaissance. So because you do distal reconnaissance first and go to the carotid later on, and there is a lower risk of procedure bradycardia and hypotension of the carotid vasoreceptor with the stent placement. So in the tandem region, either you favor stenting or no stenting, or favor stenting. So what is the case where the stenting is not favored? In the dissection, stenting is usually not favored until it is a flow limiting dissection. Most of the time with anticoagulant dissection is healed. Then if there is a large infarct or low aspect score, better not to perform the stenting, because the patient has to be on the double anteplated and sometimes the decompression is needed. Where there is a no flow or poor flow, then the stenting is better to be avoided. If there is a good collator or complete collator, because the circle of Willis is good, then you can avoid the stenting, because there is a good collator flow through the AIIMS and the flow is distorted. Dynamic IC reocclusion angiography, then no active, if there is no active reocclusion, then the stenting is not needed. If you are using the IV thrombolysis, it is better to avoid the stenting, because the patient has to put on double anteplated and chances of bleeding is more. If there is a systemic bleeding risk, better to avoid stenting, and stenting requires long-term anteplated and anticoagulant treatment. What are the factors which say that stenting to be done? If it is atherosclerotic, because chances of re-occlusion is very, very high. If there is small impact or high aspect score, then you can favor the stenting, because anteplated does not carry too much risk here. If you can get the complete or near complete reconnaissance, then stenting is favored, because sometimes you get good distal reconnaissance, but because of the carotid artery, it can block, so better to perform the stenting here. With the poor collaterals or incomplete collaterals, better to do the stenting. And if there is no active reocclusion, it is favors the stenting. In case when we defer the carotid stenting, is what is time interval? Usually we have to wait for days to week when the patient becomes better in the clinical sense. And it's said that if you do early stenting, it may pose to the higher intracranial risk. So what you have to do? Either stenting or angioplasty alone. Rescue carotid stenting patient receiving acute antiplatelet medication have more favorable outcome. So in compared to angioplasty, the stenting is more favored, and there is no significant difference in these serious complications between stenting or angioplasty. So stenting is more favored, and there is a more better outcome of 10 to 20% higher rate of favor outcome if you do stenting rather than just angioplasty alone. There may be a retrograde approach, there may be anti-gate approach, or there may be carotid stenting and first anti-gate approach is there. So retrograde approach is that first go to direct empty. So first you have to recognize the middle cerebral artery here, and then you can do the angioplasty or stenting if needed. Second is the angioplasty followed by magnetic thrombectomy. So if there is a severe stenosis, first you have to do angioplasty and then take out the clot. And if it needed, then you can place the stent. Then there may be one approach, that carotid stenting, and then followed by empty. So first you have to secure the carotid artery stenosis by the stenting, and then do the thrombectomy. So all these three approaches are valid and everybody has own preference. And it is said that it has all similar functional outcome. So if you analyze all the data, if there is a distal or proximal first, it has similar functional outcome. A potential disadvantage of distal first will be with the recurrent embolic phenomena during stent deployment. So if you deploy the stent later on, you may have thromboembolic complication, and then you can have the recurrent stroke, and you have to again reconnize the artery distally. This is a paper which shows the proximal to distal approach in the treatment of tandem occlusion, and he said that proximal region treating first is safe and effective option. So according to this school of thoughts, first treat the proximal region, place the stent, and then treat the distal occlusion. So as I said, sometimes it looks like tandem occlusion, but it's in true sense it is a pseudo occlusion. So just like in this case, here we see there's possibly there's occlusion in the vitreous segment of the ICU. So this is 60-year period with active fibrillation last 7 hours back, and you can see there's a significant diffusion mismatch here. And what we have seen on the CT angio, there was a vitreous occlusion, but when we took PSA, we found there's a occlusion of the supracoroid segment of ICA before the after the origin of the ophthalmic artery. So we place the two stent retriever, one in the midcerebral artery, another in the anterior cerebral artery. This is the midcerebral artery and this is the anterior cerebral artery. And we could get TP3 reconnection in this pseudo occlusion. It was not pseudo occlusion because it was more like a proximal occlusion, but really it was a distal occlusion. And these are the two stent retrievers. You can get the clot in the both stent retriever, and this is small hemorrhage here. Then in the atherosclerotic carotid occlusion, we may have either simple plaque here or mild stenosis. Then we may have the subtotal stenosis, or sometimes we have complete occlusion. So we have to open all these three arteries in case of proximal occlusion. So atherosclerotic regions look like this. There will be irregular, very irregular surface here, or maybe complete occlusion and with some calcification. If there is an atherosclerotic region, then it may take a longer procedure time. There is a lower reconnaissance rate, more procedure complication, and sometimes you have to perform angioplasty before and after stent placement. So, looking one of the case of the tandem occlusion, 60-year male, hypertension, alcoholism, onset at 3 a.m. left hemiparesis with the right gaze preference, NHS was 14, presented 4.5 hour window. So this is MRI means that in fact is already evolving in the MC territory. So when we see CT angio, the common carotid artery is not visible from the horizon. You can see some external carotid branches, and you can see there's a MC is not visible. So occlusion of the common carotid artery, internal carotid artery, and the MC is not visible. So it was a case of tandem occlusion. But when we perform the DSA, the common carotid artery was very well filling, but there is a severe stenosis at the origin of internal carotid artery. So first we have performed the angioplasty here, and then we place the two stent retriever, one in the MCA, another in the ECA, and there is a TK2 derecanalization here. The ECA is hypoplastic here, but luckily it was from the opposite side, so we get good recanalization here. And this is the last what we took out in the first pass. These are the two stent retriever, both are having the plots here. And this is the post-op CT after 24 hours. Again, there is some hemorrhagic conversion, but not symptomatic. There are some few other cases of acute stroke with the tandem region. Again, we can see there is a very severe stenosis at origin, and there is occluded. M1 is also occluded. So first we have done the balloon angioplasty here to pass our devices to take out the clot. So angioplasty was done first here, and then we place the aspiration catheter. Good recanalization was achieved, and then later on we place the stent, carotid stent in the. Another case we can have the dissection. First is the atherostosis, another is the dissection. Dissection is the tear in the intima, and there is a mural hematoma, and because the mural hematoma, there is a lumen is compromised here, and it may produce the source of aneurysm. Usually the classical appearance is flame-shaped occlusion, and this dissection flame may extend up to distal base. So sometimes we have flame-shaped occlusion, or sometimes we have a string side here. In axial visions are very important to diagnose the dissection. So if there is a occlusion of the ICA, but along with that it is enlarged and dilate. So if you compare this ICA to this, the ICA looks very much enlarged, but it is occluded. Then possibly we are dealing with the dissection. In the dissection, the knot is to be very hyperdense because of the embolic phenomena. In the DSA, you can see there will be contrast excavation, large contrast here, or sometimes you can see the flap. So treatment of carotid dissection in case of tandem occlusion is first we must identify the true lumen to pass our wire and the catheters, and then addressing intracorneal occlusion first, and then avoiding either carotid stenting placement according to the safe option. So first we have to do the distal occlusion, and then if it is needed or if it is a flow limiting, then we have to place the stent. Otherwise, we can just keep the patient with the anticoagulants. Sometimes if the dissection is very large, then we have to place the multiple stents. So with the dissection, usually there is a higher rate of successful intracranial repression compared to no stenting. So most of the time, the dissection does not need stenting until it is a flow limiting. And on a steady state, there is no significant difference if the patient received stenting or those not received stenting in case of the dissection. And there is no increased risk of symptomatic intracranial bleeding even if you do stenting. So this is one of the case, 35-year male without comorbidity, and you can see the impact in the superior division of MCM. It is a flame-step dissection. Patient does not have any vascular risk factor. There is a M1 occlusion here. So here we have done angioplasty followed by stenting, and as well as mechanical thrombectomy of the distal segment. This is the post-op CT. We see small reveal and the impact as the pre-thrombectomy state. Then there may be carotid web in around 2% of the cases. Usually younger female, then we can have a self-like projection in the carotid origin. Out of one out of 6 patients have recurrent stroke within 2 years on optical medical measurement. So here the carotid web, the problem is that patient may have, in spite of optimal medical treatment, there is chances of high rate of recurrent stroke. And you can diagnose this carotid web by self-like projection. So these are the classical, and it is on the posterior surface, self-like projection. And when we see the delayed phase, there is a stagnation of the contrast here. There is no formal guidelines for how to treat the carotid web, but here the stenting or arterotomy is done early because there is a high chances of recurrent stroke. So in spite of medical management, there is a very high chances that patient may have recurrent stroke, and you have to treat by the carotid stent. So one of the example, 26-year female, she had right hemiparesis. She was window period, so thrombolyzed with it and place and subjected to thrombectomy. So what we can see here, initial angiogram, there's a lot of clot here. So the tyrofibrin was infused and followed by aspiration. And there was a M1 occlusion also. So we have done thrombectomy, and 3D chelation was achieved. This is the follow-up CT angio in the same patient because we could not find any risk factor. We have done the 3D CT angio and we can find the self-like projection. So possibly it was a carotid web, and ultimately the carotid stenting was done in this same female. Then another thing is rescue stenting. The rescue stenting is when the magnetic thrombectomy fails to achieve the meaningful reperfusion, and it happens into 10 to 20% of the cases. So what are the indication for the rescue stenting? If there is a persistent vessel occlusion after multiple magnetic thrombectomy attempts, usually 2 to 4 magnetic thrombectomy passes are tried before the patient is subjected to the rescue stenting. If there is an inadequate or failed reperfusion, there is a ticket 2B after magnetic thrombectomy. If there is a high-grade residual stenosis or immediate re-occlusion, post-empty, it indicates underlying intracranial atherosclerotic disease and the rescue stenting is favored, or if there is a recurrent thrombosis despite prior thrombectomy. So how to diagnose that possibly there is intracranial atherosclerotic disease? If there is an absent hyperdense sign on the CT scan. So if there is a hyperdense sign, usually it indicates possibly there is no ICAT, but if there is an absent hyperdense sign, possibly it indicates the intracranial atherosclerotic disease. Then there is a quantitative hyperdensity measurement. You can compare the Hounsfield unit on the contralateral side. If there is a lower or asymmetrical Hounsfield unit, then possibly it suggests the intracranial atherosclerotic disease. And if the occlusion is the truncal type, long type of occlusion, then possibly it indicates the intracranial atherosclerotic disease. And this occlusion involving the long segment of major artery with the distal branches, but the distal branches are still visible. So how to suspect ICAT versus embolic occlusion on CT angio before MT? Occlusion is truncal type, it indicates intracranial atherosclerotic disease. Long segment and distal flow is visible. Embolic occlusion is a branch type occlusion, there is a abrupt cut off distal vessel. Hyperdense sign is usually absent in ICAT, related occlusion. In embolic occlusion, the hyperdense sign is present. Collector flow is often preserved because mostly it is a long-standing stenotic segment, so the collector flow is usually preserved in the ICAT. Embolic occlusion, the collector's flow is reduced. Reperfusion after empty, there is a poor response and they need the rescue stenting. In the embolic occlusion, rescue stenting most of the time is not required. Effect of antiplatelet, it improves flow and it is helpful in the rescue stenting. The embolic occlusion, it is not required. And the poor recurrence appearance, usually if you recognize the artery, the residual stenosis remains that indicate ICAT. And embolic occlusion, there is no residual stenosis. So what truncal type of occlusion is? This is called a truncal type of occlusion. There is a tapering of the vessel here, so it indicates intracranial atherosclerotic disease, and you can see still the flow in the branches. And in embolic, it is called the branching side occlusion. So artery is occluded here, and it is suddenly cut off, and you cannot see the distal flow in the branches. So here you can see the distal flow in the branches. Here the distal flow in the branches is not visible. And sometimes you can find the calcification in the intracranial vessels. Again, it is an indicator of the intracranial atherosclerotic disease. So how to do rescue stenting? Either place the stent, you can use the intracranial self-expanding stent, or you can use the balloon-mounted stent, which is the mostly coronary stent, or you can do simple balloon angioplasty. But sometimes with the balloon angioplasty, artery collapses and you require ultimately stent deployment. And either you can do the antiplatelet infusion by the thyroid vein or any other IV glycoprotein 2B3A inhibitor. So when you use the balloon-mounted stent and when you use the self-mounted self-expanding stent, if the vessel diameter is more than 2 or 2.5 millimeter, then use the balloon-mounted stent. If the vessel is small in diameter, more than 1.5 meter, better to use self-expanding stent. If the lesion length is less, then balloon mounted stent are okay. But if lesion length is long, then we have to use the self-expanding stent. If there is a mismatch between the landing zone, then the balloon mounted stent are okay. But if there is a mismatch between the landing zone, it is narrowed here, it is wider here, then we have to use the self-expanding stent. If the landing zone is straight, then balloon mounted stent works very well. But if there's a tortuosity of the landing zone, then we have to use the self-expanding stent. The outcome of the rescue stenting, we get good reperfusion in around 85% of the cases. There is a favorable functional outcome occur in around 41% of the cases. If you not treat them, half of the patient will be not benefited. So it is always better to do the rescue stenting. Symptomatic hemorrhage are although more in cases of the rescue stenting, but again it is not very significant. And mortality at 90 days is reduced in the rescue stenting, 22% versus 33%. So rescue stenting is always better rather than completely occluded artery. If you placing the stent in the carotid or in the intracranial, the antiplatelet is always challenged. So it is better to infuse the tyrosine 10 ml stent followed by 5 ml per hour for the next 6 hours. And the loading of aspirin 300 mg with the propagate 300 mg or ticagrelor 180 mg is required. So there are some example of the rescue stenting. 50-year male, diabetic, smoker, 8 hour, and we can see the complete occlusion of the MS segment from the pulmonary. So this is the stent retriever, and after first pass we can see there is a narrowing here. So that is indicative of intracranial atherosclerotic disease. More visible here after second pass. Again we can see there is a very severe narrowing here. So in this case we have to do the rescue stenting. So first we place the balloon mounted stent here. So this is the stent here, and then the artery becomes almost normal. So rescue stenting is very helpful when there is intracranial atherosclerotic disease. Another case, 65-year female, pulmonary artery disease, hypertension, 6 hours, and we can see the cutoff in the cervical segment of ICA. But when we advanced our catheter, we have seen that there is a severe stenosis in the pitcher segment of the ICA, and we place the stent in the acute setting to improve the perfusion. So this is the stent here, and there is a good anti-gate flow in the middle cerebral artery and antecerebral artery. Another case, 55-year male, hypertension, diabetes. There is occlusion of the MC here. This is the stent retriever. But after first pass, we realize there is a stenotic segment here. There is a small segment of stenosis here. So artery is going to occlude. And then we done the angioplasty. And I think in this case, we will not place the stent only to angioplasty here. And this is the post empty CT scan. There is some contrast as well. Another case, basal artery occlusion, 62-year female, presented late to us. So in case the intervention was done 30 hours after the onset of the stroke. So thanks, and thanks to my colleague at the SMS department. And, thanks to Dr. Vikram, taken some of the cases from.